This is the first pediatric arrhythmia conference in Egypt and the Middle East. Great work, and with great collaboration with international guests. It is my pleasure to present Professor Dr. Rodina Sobhy, Professor of Pediatric and Pediatric Cardiology, Cairo University. She will present pediatric bradycardia. Please start, Professor Dr. Rodina.
Thank you, Dr. Hela. First of all, I'd like to welcome حضراتكم جميعا in the conference. Today my talk will be about pediatric bradycardias. Bradycardias are bradycardia is defined as a heart rate lower than the normal limit for age. It's also should be a bradycardia that's inappropriate to the level of the activity and the clinical condition of the child, not just the number. In children, we have different heart rate ranges because they are a dynamic population. Bradycardias defined as age-based definitions. Usually we say newborns who have heart rates less than 100, infants till the age of 1 year with a heart rate less than 90, and children till the age of 10 years with a heart rate less than 60, and the more than 10 years with a heart rate less than 50 are considered to have bradycardias. Bradycardias can be physiologic or pathologic. A physiologic bradycardia can be seen in the conditioned athletes, can be encountered during sleep or in conditions with a high vagal tone. However, a pathological bradycardia may be due to an underlying systemic disease or cardiac disease. Etiology of bradycardia can be due to cardiac causes, either congenital or acquired, causing sinus node dysfunction or AV node dysfunction, namely the heart block. Like for example, this is a second-degree heart block and complete heart block. The first two slides were in a congenital patient, and this ECG shows a complete heart block in a post-cardiac surgery. You can see the complete AV dissociation. Systemic causes that can affect the heart rate and cause bradycardia include the increased vagal tone, for example, in vasovagal syncope, hypoxia, which is a common cause for bradycardia in neonates, especially the preterms, or apnea. Medications like beta blockers, digoxin, calcium channel blockers, metabolic causes or endocrine causes like hypothyroidism or electrolyte disturbances, infections, sepsis, for example, myocarditis, and neurological condition like increased intracranial pressure. In children, these causes are more than the intrinsic causes. Bradycardia has a range of presentation. If it's mild, it may be asymptomatic, okay, and can be detected accidentally during routine physical evaluation, like for example during sports participation evaluation. Infants with bradycardia, if it's not severe, also moderate, can present with non-specific symptoms like failure to thrive, feeding difficulties, and older children can present with exercise intolerance, dizziness, or even syncope. Severe bradycardias may present with hemodynamic instability and symptoms of low cardiac output and poor end organ perfusion, and may even end in cardiac arrest. as mentioned, we have intrinsic and extrinsic causes for bradycardia. So our diagnostic evaluation should include history and detailed physical examination, including symptoms, if the patient is on medication, a family history of arrhythmia or sudden cardiac death, in addition to a comprehensive cardiac examination, of course, the 12 leads ECG, a continuous ECG monitoring, the Holter monitoring, and it's indicated class 1 in evaluation of bradycardia to assess intermittent bradycardias, pauses, and to correlate symptoms with the heart rate. Exercise stress testing helps to evaluate the heart rate response. If a patient is bradycardic, we can evaluate his response to physical exertion and know if he has a chronotropic incompetence. And of course, an echocardiography is an integral part to detect structural heart defects and for cardiac evaluation. In addition to laboratory tests to evaluate or detect the extrinsic causes like electrolytes, thyroid function, and investigation to rule out infection. Okay, how do we manage a child with bradycardia? Physiological bradycardias usually do not require treatment, especially if the patient is asymptomatic. For example, a well-conditioned athlete or a bradycardia that occurs during sleep with no other symptoms during the day. These need no treatment. If there is an underlying cause, first we need to treat the underlying cause. And in symptomatic bradycardias, can be considered an emergency. We can use atropine or isoprel to increase the heart rate acutely. And finally, we have the pacemaker. We can use it either temporary in acute conditions or permanent in patients requiring having a permanent condition causing the bradycardia, not a reversible cause. Temporary cardiac pacing can be inserted epicardially, as in post-operative patients after cardiac surgery, transvenously, or transcutaneously using a transcutaneous pads, or esophageal pacing. And medications, and you can start طبعا definitely لو العيان عنده hemodynamic compromise. You can start CPR if the heart rate is less than 60 with signs of inadequate perfusion. And then we can use the medications and the temporary pacemakers. Okay, so who are the patients who might require a permanent pacemaker? A child who requires a permanent pacemaker. Indications of permanent pacemaker in children include the congenital heart block. It's, as I said, the sinus node diseases or the AV blocks. The congenital AV block, if it's an advanced second or third degree heart block having a wide escape rhythm, so the ventricular escape is infrahisian, this patient is indicated for permanent pacing. If he has a ventricular dysfunction, if he has complex ventricular ectopies, if the heart rate is less than 55 per minute in patients with structurally normal heart, or less than 70 if they are associated with structural heart disease, and of course if the patient is asymptomatic, يعني عنده exercise intolerance, عنده feeding problems, عنده failure to thrive. Recently, guidelines went lower with the heart rate to avoid too early insertion of pacemakers in patients who are asymptomatic, and now we are talking of the heart rate is less than 50 even in neonates. And actually our experience supports this very much. We tend to see children with heart rates around 50, even slightly lower, and they grow well and they get their pacemakers at older age. Unlike the congenital patients who are usually stable and tolerate the bradycardia, post-operative AV block following cardiac surgery is patients, they cannot tolerate this severe bradycardia because it's an unstable rhythm, infrahystian, and it's an acute condition for the patient. So post-operative patients with advanced second or third degree heart block that persists, guidelines بقى اختلفت. في ناس قالوا up to 10 days, you can wait to 10 days, and the European Society of Cardiology في آخر guidelines قالوا 5 days. A heart block that persists more than 5 days will need a permanent pacemaker. حتى لو العيان returned sinus after the 5th day, this is very risky. Even in some conditions, in patients who do not have an escape rhythm, some patients, if we stop the temporary pacemaker, they do not regain an escape rhythm. We get an asystole. Those patients can even insert pacemaker earlier than the indications. Also, PACES consensus in 2021 noted that it's a class 2B indication in patients who have transient AV blocks who revert normal, but they are prone to progressive AV block, like for example, patients with CCTGA, AV septal defect, heterotaxy syndromes. They are even indicated, although their heart block was transient, they can, it's a class 2B, they can insert also a pacemaker because I'm expecting they will get a heart block. Patients with sinus node dysfunction who have symptoms correlated with age-inappropriate bradycardia, if you have a complex congenital heart disease with a resting heart rate less than 40 or ventricular pulses more than 3 seconds, they are indicated for pacemaker. In patients with isolated sinus node dysfunction who have no symptoms, no minimum heart rates, according to PACES consensus, no minimum heart rate or maximum pulse duration is recommended, so long the patient is asymptomatic. As I said, 3 new guidelines referring to pediatric pacing and defibrillation, the PACES consensus, the European Society guidelines, and the HRS guidelines, they lower the limits for a pacemaker implantation to reduce too early implantation of pacemaker. Okay, and device implantation was underlined that heart rate criterion is not absolute. ممكن العيان يركب على numbers higher than the guidelines if they have symptoms and they do not tolerate the bradycardia. So, يعني still we need to consider the symptoms of the patient. Okay, so, and of course, most guidelines advise for physiologic pacing, especially in patients who require a high burden of ventricular pacing. So, finally, what I want to say is that bradycardia in pediatrics range from a benign condition to a life-threatening condition. A thorough evaluation is crucial to distinguish between physiological and pathological causes. Multidisciplinary care and long-term follow-up are essential in management of children with symptomatic or pathologic bradycardias. And the approach to bradycardia in children should be tailored to the patient's age, symptoms, and underlying cause, as the management strategies are wide from just observation in benign cases to pacemaker implantation in severe cases. Thank you.
Thank you, Dr. Rodina. Very comprehensive presentation. Any question from the floor?
Okay, thank you, Professor Rodina, our elegant female member of the electrophysiology team, the only female we have. Very nice presentation. I just would like to ask, say a scenario of a case that I had. A baby, 1.5-year-old, and he came first presenting with attacks of cyanosis. Somebody did him a Holter monitor, a 24-hour Holter monitor, showed vagotonia with a heart rate going down to 51 beats per minute. His normal was 121, and it would stay for around 1.5 seconds. The parents are very, of course, alarmed by this. They're worried, asking for anything that we could do for him. It just goes by itself. It's repeated. I think it's always precipitated by crying and agitation, so it's kind of a breath-holding attacks for the baby. But would you recommend anything for that child?
His average heart rate is normal.
121.
And it's nothing happened during the Holter monitor.
It went down. He had 2 or 3 attacks of the breath-holding attacks, and during that time, it went down to 51.
I think I'll just observe and try and manage the breath-holding spells, and then wait and see. I don't think this 51 for 1 second needs anything apart from addressing the breath-holding episodes.
Okay. Any role for vitamin D in it? For the breath-holding attacks?
Iron.
Iron, vitamin D?
Yeah.
Okay.
Iron.
Thank you.
Okay.
بس في يعني هو مش خطأ، هي دايما مش خطأ شائع. حضرتك قلتي بوست اوبراتيف لو العيان جاله كمبيوتر هارت بلوك وقعد اكتر من 5 ايام هنركب بيس ميكر even if he revert into sinus. طبعا هو كان sinus وهيفضل sinus even if he reverted to normal conduction مش sinus.
Okay.
غير خطأ غير مقصود أكيد.
And I would like to add just one thing, if I have 30 seconds. I've seen patients who reverted sinus, and then later years, they developed heart block. So that's why I totally agree with reverted to normal conduction. I'm sorry, yes. We had a patient, a post-operative patient. She had heart block. She had a pacemaker. Then few months later, she became sinus, stayed sinus for 4 years. And then once her father called, we lowered the pacemaker rate. And then the father called us and said she's feeling dizzy. So we brought her back. She's in complete heart block. We turned on the pacemaker again, and then she's still in heart block, and she changed the device and so on. So, yeah. Thank you.
Okay, our next speaker, Dr. Peter Aziz. And I would like just to take a minute to thank him very much for his visits to us in Egypt here in Cairo University, adding a lot of information, expertise, education to our electrophysiology group. He's the head of the electrophysiology unit in Cleveland Clinic Foundation. And he helps us a lot with saving lives of our children in Egypt here, especially that we deal with the poor kids. So congratulations, our electrophysiology team founded by Professor Wael Lotfi, Dr. Usama Abdelaziz for all his efforts, Dr. Rodina, Dr. Rania, Dr. Hussein. Among this financial recessions and the problems we had to arrange for this meeting, it was a lot of work from their side. Dr. Peter, when we met in Cardio Alex, we were just having a goal of having few lectures with him, and he was very promptly replying to us once he went back to the United States, when he would come to us to help us more in the cath lab. And it was first, we wanted him to give us 2 or 3 lectures. Now the electrophysiology team were able to arrange for the first pediatric electrophysiology conference in Egypt, and thank you for making always Abu Rish the leader and heading for this subspecialty. A very enthusiastic team, and very dedicated, and we're so happy with Dr. Peter's present, Dr. Shadi. And I just want to say, even Shadi understands Arabic, Dr. Peter a bit, They even sponsor the air flight tickets بتاعتهم, هم اللي دافعينها. Every time he always tries to save us money and help us as much as we can. Their aim is in هم to help as much as possible kids and to exchange and educate more and more experience to our team. Thank you again, Dr. Peter, for your presence.
هقول بس كلمة صغيرة عن الغائب